Hi everyone, I am Francesca Cerutti, gold member of 𝗧liche Italiano Endodontics. In the last webinar, we discussed about shaping. This time, we are going to talk about root canal filling, which is the last or next to last step of the endodontic treatment and is extremely important, as we will see during the webinar. So I recorded the video and I will share it with you now. At the end of the video, if you have any questions, you can write them in the chat and I will be happy to answer. So enjoy! We always talk about how to master root canal filling. And why is this step so important? Because the recent literature says clearly that 40 to 60% failures of root canal treatment are connected to an insufficient or inadequate root canal filling. And so while fixing the filling, in general, we are able to achieve a success, or at least we create the conditions for the success to happen. And all of the textbooks, old or more recent, tell us extremely clearly what are the requirements of root canal filling, because with filling we want to block all of the apical foramina, lateral canals, apical deltas, dentinal tubules, etc. And also, our filling has three main goals. The first is to help intubing any residual bacteria or irritant that is inside of the root canal system, because we know that our files will never be able to shape all the root canal system, and also we know that even if our irrigants are extremely active and extremely performant, they will never be able to kill all of the bacteria that are inside of the dentinal tubules. And so we need something that is able to intube and block those bacteria and prevent them from reinfecting the root canal system. The second goal is to avoid any kind of communication between the endodontium and the periodontium. Third, and not by importance, is to prevent reinfection, because we don't want that bacteria can leak from the coronal or the apical third and to reinfect completely the root canal system that we have so diligently shaped, cleaned, and filled. And so, what is the problem with root canal filling? The problem is that sometimes the filling is not perfect, and so there is maybe an under or overfilling of the root canal system. And the literature says that the problem is that it seems that a filling that is not adequate, so over or underextended, is associated to a higher chance of failure of the root canal treatment. We have to try to make our filling as precise as possible. But what do I mean with overextended? I mean that the root stops where you see the red line, and all of the rest of the filling is outside of the root canal system. It is inside the periodontium. The underextended filling, from the other side, is when the filling does not arrive to the end of the root canal, at least from what we can see from the radiography. But we have also another problem. When the filling fails to match three-dimensionally the root canal system, and so we have an underfilled canal, maybe the length of the obturation is fine, but three-dimensionally, this obturation is not sealing. And this can happen when we have, for example, in the case you see on the left, just some cement that was thrown inside of the root canal system, or, as you see on the right, one completely missed canal. And this is obviously an underfilling. Even if the other canals are not so bad, this tooth developed apical periodontitis because the filling was not okay. And so bacteria were able to reinfect the root canal system. And so, what do you do in a case like this? I mean, we have a failed coronal restoration. And you see that the length of the existing root canal filling is not bad. But on the other hand, we have two problems. First, it's a little bit underfilled because we see that three-dimensionally maybe we can improve this kind of root canal filling. And second, the patient doesn't even know when the coronal restoration broke. And so what does that mean? It means that bacteria have probably had a lot of times in which they can have entered the tooth, and maybe they can have reinfected the root canal system. And so my approach in this case is to retreat. I remove all the coronal restoration, all of the decay, so I can see what remains of my tooth. And then, since it's better for me to manage this case with a pre-endodontic build-up, I do a pre-endodontic build-up, even if I don't like them very much. I prefer to put some liquid rubber dam and go, but in this case I was not able to control the leakage of sodium hypochlorite into the mouth. And so I did a pre-endodontic build-up. I have my 4 walls, and then I can just do disassembling, remove everything from the root canal system, and arrive to the working length, clean adequately, and it's a C-shaped canal. So now, how do I fill? Which is the most suitable technique for this particular clinical case? Because this is a question that we have to ask ourselves every time. Which technique fits better the case, and not vice versa? And so, what are the 2 most popular materials in root canal filling? Of course, they are, on the left, 𝗥𝗶𝗹𝗹𝗶, and on the right, a root canal sealer. Why do we like 𝗥𝗶𝗹𝗹? First, it can easily change its status with temperature. If I apply heat, it starts becoming soft between 40 and 49 degrees, then it becomes plastic, 𝗥𝗡𝗃, and then it melts at 95 to 100 degrees Celsius. So according to the heat that I apply, I can modify the consistency of 𝗥𝗶𝗹𝗹. Second, it is radio opaque, so I can easily check if my obturation is good or not. Third, it is dimensionally stable, so I know that I will not have a huge contraction or huge expansion of the material. So I know that it will stay more or less as I put it into the root canal system. And then it is retreatable, which is a great advantage because if I fail, or if I have to retreat a tooth that has been treated by someone else, I know that I can easily remove the 𝗥𝗶𝗹𝗹 from the root canal system. And so it's a great advantage. But it has no adhesive qualities. That's why I need to combine 𝗥𝗶𝗹𝗹 with a root canal sealer. And we can get lost in the jungle of root canal sealers because there are many of them with different features, different composition, different properties, etc. And how can I combine 𝗥𝗶𝗹𝗹 and sealer? Well, the first way in which I can do it is with the core techniques. And so with lateral compaction of the 𝗥𝗶𝗹𝗹 or a single cone plus sealer technique. So I put the sealer into the root canal system, I take my master cone, I put it into the root canal, and then I'm fine. Or I can use worm technique. More techniques are just using the properties of 𝗥𝗶𝗹𝗹 that melts and can be packed in order to adapt more closely to the three-dimensional shape of the root canal system. And I will add more 𝗥𝗶𝗹𝗹 than sealer in these kind of techniques. And what are these techniques? They are worm vertical compaction, the carrier-based technique, or the coneless technique, or squirty technique, call it as you want. So in this case, what did I do? How did I fill this tooth? Well, I chose the bioconeless technique because in such a shape of the root canal system, I prefer to put some bioceramic sealer or hydraulic sealer inside of the root canal system, and then just to backfill with warm 𝗥𝗶𝗹𝗹 the entire root canal system. In this case, I was sure that my 𝗥𝗶𝗹𝗹 would have adapted closely to the shape of the root canal system, and this is a technique that I really like to use. And so I did my post-endodontic restoration, obviously with the post, and I did the post and core restoration, and then I prepared for an overlay. But timing is everything. When can we fill the root canal systems? What are the parameters that we have to check in order to say, okay, I can fill now? Well, the first thing we have to do is to shape, clean, dry the root canal system. When we are able to dry the root canal system, then we can fill. If we cannot dry the root canal system, it is better to postpone this step. Because if I have excessive moisture, if I have bleeding, if I have pus drainage, I can't fill. I cannot fill. These are not the conditions to close the tooth. And so it's better to leave it as is, or to put some, I don't know, calcium hydroxide inside, whatever you want, but don't fill the tooth that you cannot dry. This is very important. And then obviously you do your post-endodontic restoration, because we know that this is the real end of the endodontic therapy. What about the outcomes of these different techniques? There are two reviews that are extremely recent, one by Camilleri and Pirani and the other by another school, and both of them more or less say the same things. That is, that with the current evidence, there is no material or no technique that is superior to the others. And so the literature is saying us that you have to base on your clinical experience, because now there is no evidence that there is a technique that has an impact on the outcome of the treatment. And so you can choose what you prefer according to the clinical case, obviously. But how do I choose? My answer is choose according to the anatomy of the tooth, because in some teeth it's better to use one technique, in other teeth you cannot at all use, for example, a warm technique, and you have to go with a cold technique. In the first X-ray on the left, I use warm vertical compaction. In the second, I use single cone plus bioceramic sealer. In this one, I use a 𝗙𝗏. In that one, I used warm vertical compaction in some root canals and a carrier-based technique in another canal. So it's according to the anatomy. And also, it is according to the size of your apical preparation. Because in the case on the left, in which my apical size is 110, it's obvious that I cannot control with 𝗥𝗶𝗹𝗹 that particular obturation. I have to use MTA. So it's a completely different technique. On the left, I have a normal preparation, and so I can use whatever I want. In this case, I use the modified warm vertical compaction technique. So I use bioceramic sealer and warm vertical compaction technique, because I could fit my head plugger up to 4 millimeters to the working length, etc. And another parameter that we have to consider when we choose how to fill is the equipment that we have. Because if we are missing something, then maybe we cannot do one particular technique. And so I can use, for example, single cone and silicate-based sealer in a case in which I have reduced mouth opening, narrow preparation, and it works. It works perfectly. Or in this other case, I have a situation in which in the distal, I can use the technique that I prefer, because it's straight, the preparation is fine, I can fit my heat plugger up to 4 millimeters from the working length, so I can choose a warm technique, cold technique, whatever, it's no problem. In the mesials, on the other hand, I have these long, narrow, slightly curved canals, and so I cannot fit my heat plugger where I need it to go. And so I can use a single cone plus bioceramic sealer technique. In this case, what do? What is important for me to do is to check the fit of my 𝗥𝗶𝗹 point. When I have a nice 𝗥𝗶𝗹 point fit, then I can dry the root canal, put my hydraulic sealer inside of the root canal system, fit my cone, and then with heat, I just have to cut the part of the 𝗥𝗶𝗹 point that is extruding from the root canal opening. And so I will be also ready to do immediately the post-endodontic restoration, because if I learn how to remove, and it's extremely easy, the bioceramic sealer from the pulp chamber, nobody can stop me. I can do immediately my adhesive procedure and do immediately the post-endodontic restoration. So it's also extremely ergonomic and extremely quick as a technique. And also there is a very short learning curve, so almost everyone can do it with success in just a few times. Okay? Also another case in which I go for the single cone plus hydraulic sealer technique, when I have a particular anatomy. In this case I have a split, and so what do? Once I have found my root canals, I have shaped, cleaned them, I fit my 𝗥𝗶𝗹 points and immediately do the post-endodontic restoration, and I take the impression for my overlay. And then in the same appointment, I also do the direct restoration on the nearby tooth, in which I have an accidental pulp exposure. I did MTA, direct pulp capping, and then immediately the restoration. And you see that over time, at the 1 year follow-up, I was able to preserve the vitality of the second premolar, and the first premolar looked nice. And also you see the ramification apically. So it's a technique that works if used properly. And also another case in which I like to use the single cone plus bioceramic sealer technique is, in this case, like I have a double curvature, very long root. I cannot fit my heat plugger there. And so I will choose another kind of technique, which makes my life easier. Another case, but in this case, I used a normal vertical bone compaction technique, for example, with zinc oxide eugenol sealer. It's a normal case, and you see the resorption of the sealer over time. It works. If we apply them correctly, techniques work. There are no problems. Also in this case, in which I had to do a complex treatment, remove a thermafil that had put into a perforation of the pulp chamber floor, I did a perforation repair with MTA, and then I did the root treatment. In this case, the preparations are quite conical, and so I have no problem in fitting my heat plugger there. I use warm vertical compaction technique with a conventional sealer, and you see the healing at the 2 years follow-up. So no problem. And also you see the 3 years follow-up, but still the restoration that's looking good in place. Even in this case, warm vertical compaction plus sealer, and the lesion heals. But when I say modified warm vertical compaction, I mean that I'm using a bioceramic sealer with heat. And above all, at the beginning, there were some articles that were saying that it was better to use this kind of products with cold techniques, because they were born to be used with cold techniques. But then, some other articles, one of the latest is by Yandolo and colleagues, they say that if we decrease the heat of our heat carrier, of our backfilling gun, then we can easily use a bioceramic sealer without affecting their performances. We just have to check that the sealer is heat compatible, because some of the market are heat compatible, some are not. And so this is the outcome. You see, the canal is not easy because it's kind of calcified. I find MB1, MB2, everything in place. And then I use the warm vertical compaction technique with silicate-based sealer, so decreasing the heat of my heat carrier and my backfilling gun. Same here, in this retreatment case, I use that kind of technique. So it's repeatable. When do I use a coneless or bioconeless technique? I mean that I don't need 𝗥𝗶𝗹𝗹 points and I don't need my 𝗙𝗵𝗹 to cut the 𝗥𝗶𝗹𝗹 point. I only need the e-filler and the plugger because I put the sealer into the root canal system and then I just backfill the root canal system. And this is one example in a lateral incisor with a zinc oxide eugenol sealer. And then the same example in two upper premolars with a very particular anatomy. And you see how nicely the 𝗥𝗶𝗹 goes and fill every part of the root canal system, even a lateral canal. And so this is a technique that gives you a lot of satisfactions. Also because then your access cavity is completely clean and you can restore immediately with no problem. Also in this case, you see a case in which I use this kind of technique. You can have a little bit of extrusion of sealer. You have to control the amount of sealer that you use, but in terms of post-operative pain, if you're using bioceramic, the literature says it's like close to zero, the post-operative pain. When do I use carrier-based? I use carrier-based techniques, well, when there are situations in which I have long, thin, curved canals, or in which the patient is not compliant, as in this case, very small mouth opening, etc. And so it's easier for me to put a carrier into the root canal system. This is the only case in which I use carrier-based system. Even in this case of retreatment, in which the tooth was next to zero, because there was a less coronal structure remaining, but the patient was extremely young, I wanted to save the tooth, and you see the 3 years follow-up, everything is going nicely. How do I avoid mistakes in root canal filling? Well, first of all, I have to do a good shaping, because if my shaping is correctly tapered, it will be easier for me to clean and fill the root canal system. Second, I have to clean thoroughly because I want to remove all of the bacteria, all of the pulp remnants, but also the smear layer from the root canal system. In this way, my sealer will be able to penetrate into the dentine and to give me a higher quality of filling. And then, if I dry properly the root canal system, I have no problem. If I have, like in this case, a profuse bleeding, I can't fill. Or I'm able to stop the bleeding and then I can fill. If I'm not able to stop the bleeding, I'm not going on because these are not the conditions in which my obturation can succeed. And then I have to know the materials that I'm using. Because if I know the materials that I'm using, then I know how to manage them, I choose them correctly according to the clinical case, and everything goes smoothly. There are, as we said before, extremely different techniques, and I think that one person that wants to dedicate to endodontics at least has to master 3 of the technique. One is MTA, one is a warm technique, and one is a cold technique. In this case, you can manage all the spectrum of the clinical cases that you are going to face in your career, and I think you are going to find which is the best fitting technique for your needs and for your clinical cases. What about the equipment? What do I need to do filling correctly? Paper points, because I have to dry the root canal system. If I'm using a single cone technique or a warm vertical compaction technique, I need the 𝗥𝗶𝗹𝗹𝗶 points that are high quality and can adapt nicely to your preparation. And then I need a heat carrier, a backfilling gun, and some pluggers. Fanta Dental has developed the 𝗙𝗵𝗹, which is a heat carrier. It is very nice because it comes with different tips that can be tried inside of the root canal system until you find the one that matches better your preparation. The tip can be rotate and has a light inside, so it helps you see what you are doing. The setting of this device are nice because it's extremely easy to modify the temperature at which the system is working. And so you can range from 100 to 230 degrees, just touching one button. And then you just press the button and the device heats. It works continuously for 5 seconds and then it stops and cools down. Why? Because we don't want to overheat the periodontal ligament. We don't want to transmit heat excessively to the periodontium because we want to maintain those cells vital. And it's really fast. It takes only 2 seconds to arrive to 200 degrees. So it cuts quickly, you don't have to wait for the device to heat up, etc. It's extremely easy to use. And then it has a long-lasting battery, which is good of all if you do a lot of therapies during the day. And to set up, it's extremely easy because the tips goes inside only in one way. So you have just to push them inside and they are linked. And then you just have to turn the device on, select the temperature at which you want to heat. You get a 𝗧𝗪, and then you can go. But after heating and packing, we need to backfill the root canal system if we don't want to place a post. And so we need a backfilling gun. And Fanta developed the 𝗖𝗹𝗹. 𝗖𝗹𝗹 comes with different tips in different gauge, so you can choose the one that adapts better to your root canal preparation. You can easily screw in the tip and then you turn on the device. Even in this case, the device is kind of quick because it takes like 14 seconds to heat, so it's kind of easy. When you need to heat it up, you can put your protection on. You just press the button and the device arrives to the temperature that you have selected. If you just change the adjustment, the temperature rises or decreases according to your needs. You can go to 100, 120, 140, 170, 200 and 230 degrees Celsius. So you can cover the broadest range of temperatures and you can use it in every clinical situation, really. Even in this case, the battery is long-lasting, that for the same reason I said before, it's interesting. The handling is easy, the shape is kind of good, it's lightweight, and you just have to press and the 𝗧𝗪 is coming out from the tip. So it's very easy to use. It's easy to turn down and then you put it on its base on which you can charge it if you need. And then we have the pluggers. The pluggers have to adapt to your preparation, and so you need more than one size. Fanta has done 4 different pluggers that are in nickel titanium and stainless steel. The small head is in nickel titanium, the big one is in stainless steel, and you can recognize them by a color code. So we go from the green, which is 3570, to the black, which is 4080, to the gold, which is 0.5, 1 millimeter, and the blue, which is 0.6 to 1.2 millimeters. But remember that one of the most important steps to avoid mistakes is the fit of the 𝗧𝗪 point. Once you have done this correctly, then all the rest become easier, because you are not going to risk that your cone slips outside from the foramen if you pack, or that it's going to remain short. So you have to match your working length with the length of the 𝗧𝗪 point that you can shorten by 0.5 millimeters or 1 millimeter if you will, but then they have to match, otherwise you cannot proceed with your root canal filling. And another thing that can help you in avoiding mistakes is to take an intraoperative X-ray after you've put the gutta-percha point inside of the tooth, before filling. Because in this way you can see if your gutta-percha point is long, it's short, or it's fine. And in this way you can adapt and you can modify your shaping or change another comb, select another comb. And also another thing that you can do is to take a post-operative x-ray with the clamp still on. Because if something went wrong during the therapy, you can fix it immediately. That is extremely helpful. So I hope you enjoyed this webinar, and if you have any questions, I will be more than happy to answer.